Congenital hearing loss represents a critical public health concern that demands immediate attention in NICU practice. The data tells a compelling story. Permanent hearing loss affects 1 to 3 per 1,000 newborns when confirmed through comprehensive audiologic testing, making it the most common birth defect identified through newborn screening programs. This prevalence exceeds many other conditions we routinely screen for in the neonatal period. The transformation in screening practices has been remarkable. From 1999 to 2014, universal newborn hearing screening coverage increased from 46% to 98.4% of U.S. infants, representing one of the most successful public health initiatives in recent decades. However, this screening identifies only about 1.6% of infants who fail initial testing, with the actual rate of permanent hearing loss confirmed at 1 to 3 per 1,000 births. The consequences of undetected hearing loss extend far beyond simple auditory function. Research demonstrates that undetected hearing loss creates a cascade of developmental challenges affecting communication development, academic achievement, literacy skills, and social-emotional development. These impacts begin early and compound over time. The evidence strongly supports that early identification and intervention, particularly within the first 6 months of life, provides clear benefits for communication development. This creates the foundation for the 1 to 3 to 6 recommendation: screen by 1 month, diagnose by 3 months, and intervene by 6 months. Sound transmission follows a precise sequence, transforming mechanical energy into neural signals. The external ear, including the pinna and outer ear canal, conducts sound waves to the tympanic membrane where mechanical vibrations begin. The middle ear amplifies these vibrations through 3 ossicles, Mellius, Incus, and Stapes, which focus sound energy into the fluid-filled cochlea. This mechanical amplification overcomes the impedance mismatch between air and fluid, enabling efficient energy transfer. Within the cochlea, 2 distinct hair cell populations perform different functions. Outer hair cells respond to sound energy by producing otoacoustic emissions, measurable echoes that confirm normal cochlear function. Inner hair cells convert mechanical energy into electrical impulses, transforming sound waves into neural signals transmitted via the 8th cranial nerve through the brainstem to the auditory cortex. Normal hearing thresholds measure 10 to 15 decibels across frequencies. Disruption in sound conduction through the outer or middle ear causes conductive hearing loss, while problems in the cochlea, hair cells, or 8th cranial nerve result in sensorineural hearing loss. Each component must function properly for normal auditory perception. The development of the ear begins early in gestation and involves contributions from multiple embryologic tissues. By the 4th week, the external ear, middle ear, and eustachian tube originate from the branchial apparatus, reflecting the coordinated growth of branchial arches and clefts. A week earlier, in the 3rd week of gestation, the inner ear begins to form. This structure arises from both surface ectoderm, which creates the otic placode, and neuroectoderm, which contributes to neural elements. As development progresses, the key structures of the inner ear, the cochlea, semicircular canals, utricle, and saccule, are fully established by approximately 15 weeks. These components form the basis for both auditory and vestibular function. Importantly, the inner ear achieves adult size by around 23 weeks of gestation. This timing has clinical relevance as it explains why fetal auditory responsiveness becomes evident in the 2nd trimester and why disruptions during this window can have lasting impact on hearing and balance. Hearing loss severity classifications provide essential clinical information for planning interventions. Normal hearing typically falls within the range of 10 to 15 decibels, while pathological hearing loss begins at 16 decibels. Slight hearing loss is defined as 16 to 25 decibels, mild as 26 to 40 decibels, moderate as 41 to 55 decibels, moderately severe as 56 to 70 decibels, severe as 71 to 90 decibels, and profound as 91 decibels or greater. Even slight and mild hearing loss can significantly affect language development in young children and may progress with time. This challenges the assumption that minimal hearing loss has little clinical relevance. Research consistently shows that children with mild degrees of hearing loss experience delays in speech and language development compared with peers who have normal hearing. For bilateral hearing loss, severity is determined using the better functioning ear. This method reflects the fact that the ear with stronger function provides the primary basis for speech perception and language acquisition, which directly shapes both clinical decision-making and prognostic counseling. These classifications guide real-world management. Children with moderate to profound hearing loss often require amplification devices such as hearing aids or cochlear implants. Those with slight to mild loss may benefit from accommodations including preferential classroom seating, frequency modulation systems, or other supports. No level of hearing loss should be dismissed when evaluating language and educational development. Because progressive loss is mixable, ongoing monitoring is necessary to support optimal outcomes. Sensorineural hearing loss represents pathology involving cranial nerve 8, outer hair cells, and inner hair cells of the cochlea that impairs neuroconduction of sound energy to the brainstem. This type of hearing loss affects the sensory and neural components of the auditory system, distinguishing it from purely conductive problems. The pathophysiology involves failure of sound transmission within the cochlea itself, affecting both hair cell populations and the eighth cranial nerve. When outer hair cells malfunction, otoacoustic emissions disappear. When inner hair cells fail, the conversion from mechanical to electrical energy becomes compromised, disrupting neural transmission to the auditory cortex. Both OAE and ABR testing detect sensorineural hearing loss, making screening straightforward. This detection capability occurs because sensorineural pathology affects the cochlear mechanisms that both tests evaluate: outer hair cell function for OAEs and neural pathway integrity for ABR. The screening results will show abnormal responses on both tests when sensorineural hearing loss is present. Common etiologies in the NICU population include genetic mutations, ototoxic medications like aminoglycosides and loop diuretics, hyperbilirubinemia requiring exchange transfusion, and congenital infections such as CMV. The permanence of sensorineural hearing loss makes early identification crucial for implementing appropriate intervention strategies, including hearing aids or cochlear implants. Conductive hearing loss results from anatomic obstruction of the outer ear or middle ear that blocks sound transmission to the inner ear. The cochlear function remains intact, but mechanical sound conduction becomes impaired before reaching the sensory apparatus. Permanent conductive hearing loss involves structural abnormalities such as atresia of the external auditory canal or fusion of the middle ear ossicles. These anatomic malformations prevent normal vibration transmission through the conductive pathway. Atresia affects the external canal, while ossicular fusion prevents proper movement of the malleus, incus, or stapes. Transient conductive hearing loss occurs from debris in the ear canal or fluid in the middle ear space. These conditions are often reversible once the blockage clears or fluid resolves. Middle ear fusion is particularly common in NICU graduates and can compound existing hearing difficulties. Both OAE and ABR testing detect conductive hearing loss because the obstruction prevents sound energy from reaching the cochlea effectively. The conductive block interferes with stimulus delivery to the outer hair cells, causing OAE failures, while also reducing sound intensity reaching the neural pathways detected by ABR. Clinical management differs based on whether the conductive loss is permanent or transient. Permanent losses may require surgical intervention or bone-anchored hearing aids, while transient losses often resolve with medical treatment or observation. Neural hearing loss involves pathology of the myelinated fibers of cranial nerve, 8 or inner hair cells that impairs neuroconduction of sound energy to the brainstem. Critically, the function of outer hair cells remains intact, creating a distinctive testing pattern that separates this condition from other hearing loss types. Also called auditory dysynchrony, this condition creates a paradoxical screening result. Patients will pass OAE testing, but fail ABR testing. This occurs because outer hair cells continue producing otoacoustic emissions normally, while the neural pathway disruption prevents proper brainstem response generation. This testing pattern is pathognomonic for neural hearing loss. NICU infants face the highest risk for neural hearing loss. The Joint Committee on Infant Hearing 2007 specifically states that infants cared for in the NICU for greater than 5 days are at highest risk for neural hearing loss and should be screened only with AABR. This recommendation exists because OAE testing will not identify auditory neuropathy. The clinical significance is profound. These infants may appear to have normal hearing based on OAE results, leading to missed diagnoses if inappropriate screening methods are used. NICU patients must receive AABR screening exclusively because OAE screening fails to detect this condition. This represents a critical screening protocol that directly impacts diagnostic accuracy and early intervention opportunities for this vulnerable population. The Joint Committee on Infant Hearing, 2007, established 11 specific risk factors for permanent hearing loss that form the cornerstone of clinical surveillance protocol cells. These risk factors serve dual purposes: identifying infants requiring immediate audiologic evaluation and guiding long-term surveillance strategies for those who pass initial screening. Risk factors marked with asterisks carry heightened significance. They indicate higher risk for delayed onset or progressive hearing loss that may emerge months or years after birth. This distinction drives surveillance intensity and frequency recommendations, making these markers critical for clinical decision-making. The epidemiologic reality underscores why ongoing surveillance remains essential. Hearing loss rates double from birth to school age, increasing from 1 to 3 per 1,000 newborns to 3 to 4 per 1,000 at school age. This doubling occurs through 3 mechanisms: mild hearing loss is missed by newborn screening tools, delayed onset hearing loss such as that associated with cytomegalovirus, and late onset hearing loss secondary to trauma or chemotherapy. Even infants who pass initial screening require ongoing surveillance when risk factors are present. The screening technology has limitations. Newborn screens detect only more significant hearing losses and remain least sensitive to mild impairments. Yet even slight hearing losses impact language development, making continued vigilance necessary throughout the critical early developmental period when intervention effectiveness remains highest. Risk factors 1 and 2 represent parent-reported information that requires careful clinical interpretation and follow-up planning. Caregiver concerns regarding hearing, speech, language, or developmental delay carry particular weight because they're associated with increased risk for late onset or progressive hearing loss not detected during newborn screening. Parents often notice subtle changes in responsiveness or developmental patterns before formal testing reveals problems. Family history of permanent hearing loss requires sensitive exploration since parents may not initially be aware of relevant family history until discussing possibilities with relatives. This factor demands genetics consultation for all families with affected infants, regardless of whether family history is initially reported. The hereditary component of hearing loss is substantial. At least 50% of congenital hearing loss has hereditary origins, with nearly 400 syndromes and hundreds of genes identified. The clinical significance extends beyond the individual infant. When family history emerges for an infant who initially passed screening, ongoing surveillance becomes mandatory with at least one follow-up audiologic assessment by 24 to 30 months of age. This surveillance timeline recognizes that hearing loss rates double between birth and school age, requiring systematic monitoring to capture progressive or delayed onset cases. Both factors emphasize the importance of genetics consultation, which provides families with information on etiology, prognosis, associated disorders, and recurrence risk for future pregnancies. This genetic evaluation can guide testing for specific mutations and syndromes, informing both immediate management and family planning decisions. Medical complications account for 40% of childhood permanent hearing loss, making NICU care the most significant modifiable risk factor. Risk factor 3 encompasses infants requiring neonatal intensive care for greater than 5 days, plus hyperbilirubinemia requiring exchange transfusion regardless of length of stay. This dual threshold recognizes both duration-dependent and severity-dependent risks. The associated exposures carry specific ototoxic risks that accumulate during critical developmental periods. Extracorporeal membrane oxygenation represents one of the highest risk exposures, with studies documenting significant rates of sensorineural hearing loss among survivors. Assisted ventilation, while life-saving, involves multiple potential ototoxic exposures, including sedative medications and pressure changes. Ototoxic medications pose particular risks in the NICU population. gentamicin, and tobramycin, commonly used aminoglycosides, carry well-documented ototoxic potential that may be enhanced by genetic susceptibility factors. Several mitochondrial DNA mutations associated with aminoglycoside-induced hearing loss occur in approximately 1 to 1.8% of NICU populations, though rapid genetic screening remains unavailable. Loop diuretics, including furosemide and Lasix, create additional risk, particularly when used in combination with aminoglycosides. These medications can cause both temporary and permanent hearing loss, with risk factors including dosage, duration of therapy, and concurrent nephrotoxic medications. The 5-day threshold reflects evidence that longer NICU stays correlate with increased exposure to multiple risk factors simultaneously, creating cumulative ototoxic burden that exceeds individual medication effects. In utero infections constitute a diverse group of pathogens capable of causing both immediate and delayed hearing loss. Cytomegalovirus stands as the most significant infectious cause, marked with an asterisk to denote its particular association with delayed onset and progressive hearing loss. Most infants with congenital CMV infection show no clinical findings at birth, making diagnosis challenging despite the infection's profound impact on auditory development. Zika virus has emerged as a neurotropic pathogen associated with early and possibly delayed onset hearing loss. Because Zika infection often occurs with central nervous system abnormalities, affected infants require screening with AABR rather than OAE to ensure detection of potential auditory neuropathy patterns. The traditional torch infections, toxoplasmosis, rubella, herpes virus, and syphilis, each carry specific patterns of auditory involvement. Rubella historically caused significant hearing loss before widespread vaccination, while herpes virus can cause both congenital and acquired hearing loss depending on timing of infection. The challenge with in utero infections lies in their often subtle presentation at birth, combined with potential for progressive hearing loss over time. Many infected infants appear normal initially, with hearing deterioration emerging months or years later. This delayed progression necessitates long-term audiologic surveillance even when initial screening results appear normal. Recognition of in utero infection requires high clinical suspicion combined with appropriate diagnostic testing. The hearing loss patterns may be unilateral or bilateral and can progress from mild to profound over time, making early identification and ongoing monitoring essential for optimal intervention timing. Cytomegalovirus represents the most common medical cause of both early and delayed onset hearing loss in infants and children, making it the single most important infectious risk factor for NICU practice. The clinical challenge lies in its often silent presentation. Most infants with congenital CMV infection show no clinical findings at birth, causing the diagnosis to go unrecognized despite significant long-term implications. The epidemiologic impact is substantial, with CMV being the leading infectious cause of sensorineural hearing loss worldwide. Unlike other causes of hearing loss that remain static, CMV-associated hearing loss characteristically progresses over time, with children experiencing deterioration months or years after birth. This progression makes ongoing surveillance mandatory throughout childhood. Treatment with valganciclovir remains controversial due to increased risk of side effects, particularly in infants without obvious clinical findings or existing hearing loss. Current evidence suggests potential benefit for symptomatic infants, but treatment decisions require careful risk-benefit analysis, considering medication toxicity against potential hearing preservation. The pathophysiology involves both sensorineural and auditory neuropathy patterns, reflecting CMV's capacity to damage multiple components of the auditory system. The virus affects inner hair cells, outer hair cells, and neural pathways, creating diverse hearing loss presentations that may not follow typical patterns. Detection requires high clinical suspicion since routine screening for CMV is not universally performed. Diagnosis relies on PCR testing of urine, blood, or saliva within the first few weeks of life, as later testing cannot distinguish congenital from acquired infection. The association between viral burden in infancy and subsequent hearing loss emphasizes the importance of early detection and monitoring. Risk factors 5 and 6 represent visible anatomic markers that reflect abnormalities in embryologic development of the ear. these findings occur commonly in both well baby nursery and NICU populations, making clinical recognition essential for early identification and appropriate surveillance planning. Craniofacial anomalies include atresia, microtia, and temporal bone anomalies that directly affect auditory structures. These defects reflect disrupted branchial apparatus development beginning at the 4th week of gestation. The external ear, middle ear, and eustachian tube all develop from the branchial apparatus, while the inner ear develops separately from surface ectoderm and neuroectoderm beginning in the 3rd week of gestation. Atresia involves absence or underdevelopment of the external auditory canal, creating conductive hearing loss through mechanical obstruction. Microtia represents underdevelopment of the pinna, often associated with canal atresia. Temporal bone anomalies can affect middle ear structures, including ossicular development and function. Physical findings associated with syndromes carry particular significance because they indicate systemic conditions with potential for progressive hearing loss. White forelock represents the classic marker for Waardenburg syndrome, the most common autosomal dominant syndromic hearing loss, occurring in 1 to 4% of children with hearing loss. This visible sign alerts clinicians to investigate for associated sensorineural or conductive hearing loss and heterochromia iridis. The embryologic timing explains the clustering of these findings. Disruptions during critical developmental windows affect multiple structures simultaneously, creating recognizable patterns that guide both diagnostic evaluation and ongoing surveillance protocols. Risk factor 7 encompasses syndromes associated with hearing loss or progressive late-onset hearing loss, marked with an asterisk to denote particular risk for delayed presentation. These conditions represent complex genetic disorders where hearing loss may be present at birth or develop over time, requiring lifelong audiologic surveillance. Neurofibromatosis, osteopetrosis, and Usher syndrome represent 3 major categories with distinct clinical patterns. Usher syndrome stands as the most common cause of autosomal recessive syndromic hearing loss, affecting 4 to 6% of children with hearing loss. This condition combines sensorineural hearing loss with progressive retinitis pigmentosa, creating unique management challenges as affected individuals develop increasing visual impairment over time. Waardenburg, Alport, Pendred, and Jervell Lange Nielsen syndromes represent additional frequently identified conditions with specific audiologic and systemic manifestations. Each syndrome carries distinct inheritance patterns and associated features that influence both prognosis and management strategies. The progressive nature of hearing loss in many of these conditions necessitates ongoing surveillance beyond the newborn period. Unlike isolated hearing loss that remains static, syndromic hearing loss may worsen over months or years, requiring periodic audiologic assessment and intervention adjustments. Early syndrome recognition enables genetic counseling, appropriate specialty referrals, and anticipatory guidance for families. The presence of hearing loss as part of a broader syndrome often indicates need for multidisciplinary care involving genetics, ophthalmology, cardiology, and other specialists depending on the specific condition identified. Usher syndrome represents the most clinically significant syndromic hearing loss due to its combination of sensorineural hearing loss with progressive retinitis pigmentosa. Affected individuals develop vestibular problems and progressive visual loss leading to blindness with increasing age. Early diagnosis becomes critical because visual means of communication will not be available as the condition progresses, making auditory rehabilitation and early intervention essential for optimal outcomes. Waardenburg syndrome occurs as the most common autosomal dominant syndromic hearing loss, affecting 1 to 4% of children with hearing loss. The classic presentation includes heterochromia iridis combined with either sensorineural or conductive hearing loss. Recognition relies on identifying the characteristic physical findings, including white forelock, dystopia canthorum, and pigmentary abnormalities. Pendred syndrome represents the second most common autosomal recessive cause of syndromic hearing loss, characterized by severe to profound hearing loss, combined with euthyroid goiter that typically presents during adolescence. The condition often involves Mondini dysplasia or dilated vestibular aqueduct, identifiable through computed tomography examination of the temporal bones. Jervell Nielsen syndrome creates life-threatening complications through prolonged QT segment on electrocardiogram associated with sudden infant death and syncope episodes. Children with QT prolongation require immediate cardiology consultation for risk stratification and management. The combination of profound hearing loss with cardiac arrhythmia risk necessitates coordinated care between audiology and cardiology specialists throughout childhood and beyond. Each syndrome requires specific surveillance protocols and specialist coordination to optimize outcomes and prevent complications. Risk factor 8 encompasses neurodegenerative disorders marked with an asterisk indicating delayed onset or progressive hearing loss risk. Hunter syndrome represents a lysosomal storage disorder that can affect auditory function through progressive tissue accumulation. Sensory motor neuropathies, including Friedreich ataxia and Charcot-Marie tooth disease, affect peripheral nerve function, with potential auditory nerve involvement developing over time. These conditions typically present with systemic neurologic symptoms that may overshadow hearing concerns initially. Charcot-Marie tooth disease represents a genetically heterogeneous group of hereditary motor and sensory neuropathies with variable presentations ranging from demyelinating to axonal disorders. Friedreich ataxia causes progressive ataxia with potential eighth cranial nerve involvement as part of the broader neurodegenerative process. Risk factor 9 involves culture-positive postnatal infections, particularly confirmed bacterial and viral meningitis, with emphasis on herpes viruses and varicella. Meningitis creates increased incidence of sensorineural hearing loss through direct inflammatory damage to cochlear structures and auditory pathways. Among survivors of neonatal meningitis, hearing problems occur in 25.8% of cases according to prospective studies. Children with cochlear implants face increased meningitis risk, particularly from Streptococcus pneumoniae, making vaccination according to high-risk schedules essential. The bidirectional relationship between meningitis and hearing loss, where hearing loss increases meningitis risk in implant recipients, while meningitis causes hearing loss, requires careful clinical management and ongoing surveillance. Both risk factors necessitate long-term audiologic monitoring since hearing deterioration may develop months or years after initial presentation. Risk factors 10 and 11 represent conditions encountered after hospital discharge that require ongoing vigilance throughout childhood. These factors distinguish themselves by occurring beyond the neonatal period, necessitating long-term surveillance strategies and parental education about warning signs. Head trauma, particularly basal skull or temporal bone fractures requiring hospitalization, creates direct mechanical damage to auditory structures. The temporal bone houses critical components of the hearing mechanism, making fractures in this region high risk for both immediate and delayed hearing loss. The severity threshold requiring hospitalization indicates significant trauma with potential for lasting auditory consequences. Chemotherapy, while rare in children, represents a potentially reversible cause of hearing loss when identified early. Certain chemotherapeutic agents, particularly platinum-based compounds, carry significant ototoxic potential. The reversible nature of some chemotherapy-induced hearing loss makes early detection and intervention crucial for optimal outcomes. All children with identified risk factors require ongoing surveillance in the medical home setting with at least one follow-up audiologic assessment. The frequency and intensity of surveillance should increase for children with risk factors specifically associated with delayed onset or progressive hearing loss, as indicated by asterisk markings. The post-discharge nature of these risk factors emphasizes the importance of comprehensive discharge planning, parental education, and strong communication between hospital-based teams and primary care providers. Families need clear guidance about when to seek audiologic evaluation and how to recognize potential signs of hearing deterioration that may develop months or years after the initial insult. Genetic factors cause at least half of all congenital hearing loss cases, making hereditary causes the dominant etiology you'll encounter in NICU practice. This prevalence directly impacts your diagnostic approach and family counseling conversations. Nearly 400 syndromes and hundreds of genes associate with hearing loss, but the critical clinical distinction separates syndromic from non-syndromic presentations. 30% of genetic hearing loss occurs with syndromic features requiring comprehensive evaluation for associated anomalies, while 70% presents as isolated hearing loss without additional medical concerns. Among non-syndromic cases, the inheritance patterns create a counterintuitive clinical reality. Autosomal recessive inheritance accounts for 75 to 85% of cases, meaning most infants with significant hearing loss are born to parents with normal hearing. This recessive pattern occurs when two carrier parents, each with normal hearing, have a 25% chance with each pregnancy of having an affected child. Autosomal dominant inheritance represents 15 to 24% of non-syndromic cases, typically presenting with family history of hearing loss and often showing progressive patterns. X-linked inheritance accounts for only 1 to 2%, primarily affecting males with hearing loss that may not manifest until after the newborn period. This genetic landscape means family history alone cannot rule out hereditary hearing loss, making genetic evaluation essential for every infant with confirmed hearing loss, regardless of family history. Connexin 26, encoded by the GJB2 gene, represents the single most important genetic target in neonatal hearing loss evaluation. This gap junction protein functions within the cochlear connective tissues to maintain the ionic environment necessary for normal auditory transduction. When mutations disrupt this protein's function, the resulting hearing loss is typically profound and present from birth. The clinical significance of GJB2 mutations cannot be overstated, accounting for up to 50% of all profound non-syndromic hearing loss cases. This prevalence makes Connexin 26 testing the highest yield genetic test in the initial evaluation of any infant with confirmed hearing loss. Among the more than 100 identified GJB2 mutations, the 35DELG mutation demonstrates remarkable frequency, representing up to 70% of all Connexin 26 mutations. This single nucleotide deletion creates a frame shift that completely eliminates protein function. The high prevalence of this specific mutation makes targeted genetic testing both clinically practical and cost-effective. From a clinical management perspective, Connexin 26-related hearing loss typically presents as stable, profound sensorineural hearing loss without associated anomalies. This knowledge helps families understand that the hearing loss is unlikely to progress and that the child's cognitive development should proceed normally with appropriate early intervention. The absence of syndromic features also means that additional medical surveillance beyond routine care is typically unnecessary.